So, I decided to do a presentation on presenting the patient and doing it well on the wards. And this is for you, medical students, who rotate through the vascular surgery service. So, why is doing a good presentation important? I mean, the obvious is that you share information with your colleagues about the status of a patient and his care and plans. But I think more importantly, it's an opportunity for you to stand out. I think most of you will do residency and you need letters of reference or recommendation. And as an attending, we tend to remember students who've done a good job, and I think being inquisitive is one important aspect, I guess, but it's definitely not enough. And I think if you do an excellent presentation where I clearly understand that you understand the disease process, patient management, I think you would definitely stand out. I do remember most students who did a very good job, and I strongly believe that it's a huge opportunity for you to stand out and get the letters you need for your residency. So, how do you do it, and what is a good presentation? I think one aspect of it is that you're telling a story, and this follows basic plot structure, which is every story has a beginning, a middle, and an end, and everything makes sense at the end. And that's how your presentation should flow. Sentence need to lead into the next one in a logical manner until you reach a logical conclusion. The story needs to be brief, and that's I'm afraid the hard part. And brief, I don't mean short. I guess it stands for short, but it's a presentation where all the essential elements are present, and we clearly understand the patient's disease process, procedure, current status, and with that information, I can manage the patient. So this is important. Anyway, so how do you do it? I must say I had to think about this for a while to see, to find a technique I think that would be useful and a technique that could be taught. So this is what I came up with, and hopefully it'll be helpful to you. So the first thing you have to do is to gather the information. And the two important steps are why and how did the patient present, and what procedure did the patient undergo. So I'm assuming you on the vascular surgery service or surgical specialty, and this is relevant to you. At that point, once you know this aspect, I'm afraid you're going to have to do some academic work. There's no way around it. You cannot present a patient if you do not understand or have no idea what the disease process is and what type of procedure did the patient undergo. So I would stop looking at the chart, open Google, and do some reading. I think it can be very basic, but if you do this preliminary work, the rest of the information gathering process will be a lot easier and will make sense to you. And you will almost look for that information because you know what you have to look for. So spend 30 minutes trying to understand the disease process. So if a patient is a claudicator and presented for low extremity bypass, try to have some idea what claudication is, what are the associated risk factors for that disease process, and what are the treatment options. Just some basic reading, nothing in detail. You don't have to dish out article. Then when you look or you determine what procedure was performed, try to be specific. I mean, I have often medical students who say, well, the patient had a low extremity bypass. Well, that's not helpful for me because there are many vessels in the leg, not that many, but several, and a bypass can be above the knee, below the knee, to a tibial or pedal vessel, and that does make a difference. For the same reason, you're not going to be on tell a pulmonologist on the pulmonary service, patient with pulmonary disease. That's not specific. We need the specific when it comes to our specialty. Of course, what is the current post-op day? What is the post-op course of the patient? And this information can be gathered in a very chronologic fashion. I don't think you have to think too much. At this point, it's easy. Next is, what is the status of the patient today? Your best reference obviously is the patient, so you should go to the bedside, but maybe you gather that information from the morning rounds. We tend to do staff round in the afternoon, so just beware. At least you know what the status of the patient is that day. And that should include a physical exam. And focus on the important aspect in the physical exam and the patient's status. So how is the patient overall? How is the status of the procedure? If I did a bypass, it's important for me to know if the bypass is open or not. Does the patient if he has rest pain or not? And then the rest of the physical exam, of course. And this relates to the specifics. So if the patient has aortic aneurysm repair, you have to know, you have to examine the patient and know what his abdominal status is. If it was an open repair, what his lower extremity vascular exam is. This is important. That's why knowing about the disease process and the procedure will help you in gathering that information. Of course, the rest, and that is relevant. So the cardiac exam, pulmonary exam, and so on. But still focus on what is important and related to the patient's risk factor and the current procedure. Look at the labs. 90% of the time, what is important to us is the hemoglobin, the white count, the creatinine. And as far as imaging is concerned, duplex study, which is an ultrasound with a Doppler added to it anyway, and a CT or a CT angiogram. So if any of those were done that day, you need to know it. Also, you need to know, if you know the white count today, you need to tell me what the white count was the day before, right? I mean, otherwise it is not useful information. Just last week we had a student presenting a patient, and when we got to the lab, you just say white count 19,000 and never really brought up any possible cause or reason why this white count was 19,000. So it is not helpful. But if you tell me that the white count was, on admission 9, then postoperatively on post-op day 1 it was 19,000 and it's currently 10, this is useful. This means that this is a reactive leukocytosis and there's nothing to worry about. Again, the rest is not as important, but I recommend, just in case. I don't know about all attendings. I know I wouldn't care if it's not helping in the patient care, but some attending may ask you certain details. So if you have all labs available to you, that may be helpful. So at that point, the only thing you've done is sort of gather information in a logical way. I would recommend, after you have this info, that you do a little more reading. Again, it will solidify your knowledge. We ask you on the vascular service to present 2 patients over the 2 weeks. So I believe you would have plenty of time to do a little rating on your respective patient. And now you need the hard part, is to summarize everything in a logical way, and that makes sense, and that is helpful to the team. That's why you have to think. It's important to think about what you're saying. We don't want you to just give us a bunch of info. That is not helpful. So this is the way I would do it. This is probably the way I present all my patients. I must say I had to think about it a little bit. But anyway, so the age and gender of the patient, that's the first thing you present. So this is a 64-year-old gentleman, 65-year-old woman, who presented with a long-standing history of, and then that's why you have to be aware of the risk factors. Because, and those are the risk factors associated with the disease process. So that patient presented with an X day month history of. So it's important to quantify and qualify any disease process. So a 30-day history of claudication. At that point, we don't need to make a diagnosis. This is not a patient you're presenting in clinic with a broad complaint. You presenting a patient who has a diagnosis and underwent a surgical intervention. So he underwent a procedure. Again, be specific. If it's a bypass or an endarterectomy, try to know where it was done, from what vessel to what vessel, what conduit was used, because this is important info for us. And then I would say the patient is currently on post-op day X. Sorry, I have my thing in the way here. So then his hospital course has been. So this is where you have to, either it's straightforward, we're excellent surgeons, so none of our patients have complication. Unfortunately, this is not the case. So either the patient's course has been uneventful, that is all I need to know, or the patient postoperative course has been complicated by an episode of chest pain. And then I would tend to give the detail of that process and not go any further. So if the patient, his hospital course has been complicated with an episode of chest pain, EKG and troponin were obtained. Those were found to be, the troponins were elevated, was elevated, sorry. The EKG was abnormal. The cardiology service was consulted, and their current recommendation are to treat the patient conservatively, and they're planning to cath them in the future. That's good info, and I think brought into at the right time into that presentation process. So I thought about this because, you know, we classically are taught to follow that sub format, but when I listen to it, I fall asleep. It's not helping me. I don't like it. So this is what I would recommend you do. So what the hospital course at that point is important, and it's okay to give the specifics. And then you jump, the next step, once you've addressed the complication, is to talk about the actual procedure. So then I would say, from a vascular standpoint, the patient is doing well. His rest pain has been alleviated with a bypass. On physical examination, the wounds are clean. There's no drainage. The patient has a strong Doppler signal in the foot, and the graft is palpable. Perfect. And then you can mention the rest. And I would go back to the risk factor. If you had to address issue, let's say this is a patient with coronary disease, renal failure, and diabetes, I would tend to say, well, from a renal standpoint, patient creatinine has remained unchanged, his diabetes is well controlled with his current schedule, and so on. And then you finish by the overall plan and discharge planning says. So in conclusion, this patient is post-op day X from a femoral distal bypass, had essentially an uneventful course. The plan is to discharge him when he's able to ambulate freely and after physical therapy has been consulted. So let's run through this. I will do it. I will just make up an imaginary patient. I'll give you a quick presentation. So this is a 64-year-old gentleman with a long-standing history of diabetes mellitus, hypertension, heavy smoking, stage 3 renal failure, who presented with a non-healing wound in the right lower extremity that has been managed conservatively initially. Unfortunately, he failed to heal that wound and was subsequently admitted for a distal bypass. He's currently post-op day 4 after a femoral posterior tibial artery bypass that was done with a greater saphenous vein. His postoperative course has been unremarkable except for an elevation in his creatinine from 1.8 to 2. The patient, however, was rehydrated and now his creatinine has normalized. From a vascular standpoint, the patient states that he has no lower extremity pain. His pain is well controlled with the current PCA. His wounds are clean, dry. There is no erythema, no drainage. I can palpate the graft, and he had an excellent signal in the dorsalis pedis and posterior tibial pulse. Posterior tibial artery. From his renal standpoint, as mentioned previously, his creatinine has normalized with hydration. This is currently not an issue. His blood sugar has remained stable on his current protocol, and his diet has been advanced. Overall, the patient is doing well, and the plan is to discharge him after physical therapy has assessed him. So there you go. Something like that. Short, but everything I need to know is included. Finally, you have to practice. There are no secrets. Even Da Vinci said if most people knew how much time I have dedicated to my craft, they would not consider me a master. And I think that's true. We tend to admire people who have mastered their craft, regardless of what it is, without realizing how much effort they dedicated in perfecting their craft. So my recommendation is practice that presentation. Once you can either write it down or write the key point, but then practice out loud if possible at least 3 times. And I think if you want to go over the top, you know it by heart, and that is definitely very impressive. Again, I hope this info has been useful for you. I'm probably going to post other tips. I mean, stuff they don't teach you in medical school that are actually important. Unfortunately, the basic scientists have taken over your education, and I think we're starting to see the end result. Anyway, I think what would be useful and what people have asked for is not tying. We just interviewed a medical student for the residency program, and the student was telling me she should look all over YouTube for a video on knot tying techniques, and she couldn't find any. So I figured that might be useful to you guys. And of course, I would probably do try to find a similar technique or presentation on the HNP in clinic and the presentation of the patient in clinic, which is a little different because at that point you need to make a diagnosis. Anyway, again, I hope this is good. Let me know. My email is Dodafray. There we go. I'll give you my home email, comcast.net. So if you have any suggestion, let me know. Thank you.